Okay, so the first step is getting the order. An indication for an ABG order would be cyanosis or shortness of breath or anything really to see or diagnose the respiratory problem. Secondly, I will check the patient's charts. I will look at the oxygen device that he or she is on, the FiO2 setting, and how long the patient has been on that device and setting. I will also look at contraindications such as arterial shunts or grafts. I'll look at any negative Allen's tests, and I'll also check to see if there has been any anticoagulants given to the patient. This could be problematic because they will not clot at the point of where I stick them, so they need to be able to clot their own blood before I can stick them. And the third step is gathering my equipment. I will have to make sure I get a heparinized needle, a needle cap for protection, gauze, a band-aid, that's optional, a biohazard bag, sanitation solutions such as an iodine strip and an alcohol prep pad, the requisition slip, and the air bubble cap. I'll also get a towel for if you have to hyperextend the wrist, this could be easier on you. And also I'll get a bucket or an ice slush for the ABG if I plan to take more than 15 minutes to run the ABG. And the limit for waiting on analyzing an ABG is 1 hour. After an hour, you're gonna have to resample the person. Alright, now I'm going to fill out my requisition slip. I'm going to have the name, the temperature, the room number of the patient, the date, the time, and the FiO2 settings, and the device as well. Now I will go into the room, knock on the door, introduce myself to the patient. Hi, I'm Brian. I'm from the respiratory department. I'm here to take an arterial blood gas sample. I'm gonna check their identification. I can get their name and date of birth and confirm with their armband. I'm going to explain the risks to the patient. Some risks could be there's pain involved, slight pain. You can get skin infection, and also I can cause nerve damage. If the patient understands the procedure and as well as the family, I'm gonna go ahead. So first, I'm gonna wash my hands. I'm going to determine which arm I want to do it on. Like I said before, I'm going to look at any contraindications to see if they have a shunt or a graft. A good way to tell if they can't do it on a specific arm is if you can't do a blood pressure on the arm. That's already a big giveaway to not doing on the arm. You should move on to another arm. So this arm is the right arm, and I choose to do it on the radial artery. There are also the femoral artery and the brachial artery I can do the stick on. So for each artery, I will have to stick the patient at a different angle. For the radial artery that I'm doing, I'll stick it at a 45-degree angle. For a brachial artery, I'll stick it at a 60-degree angle. And for the femoral, I will do a 90-degree angle. Alright, now I'm going to do Allen's test. So how I do that is I will cover the radial artery and the ulnar artery, and I'll have the patient open and close their hand until blood goes away from the palm and it turns white. Once I take off the pressure of the ulnar artery, blood should rush back to the palm within 5 seconds or less. If they're unconscious or they can't comply with my instructions of opening and closing their hand, I can just do a modified Allen's test by occluding both vessels, the radial and ulnar, and pushing the palm and the blood back into the body. That will create the white look that the Allen's test would create, and I can just let go of the ulnar like before. If this arm fails the Allen's test, I can move on to a different site to do the puncture, such as the other arm, the radial, or the femoral. So I'm also going to, before I do any poking, I had to make sure that they have been on supplemental oxygen for at least 30 minutes. Now I will start my procedure. I'll ask if I can put the gauze on their arm just to be ready. I'll feel where their pulse is. Alright. I'm going to put some gloves on. And it's advised to go a glove size smaller so you're able to feel the pulse without having the glove get in your way. Alright. So now I'm going to take an iodine pad and start from the point of where I'm going to stick the patient and circularly rotate the cleaning site 2 inches away from the middle. Now I'm going to take an alcohol prep pad and do the same. Toss this away. And it's also a good idea to clean the tip of your finger gloves, because when you're palpating, you don't want to introduce any pathogens or any microbacteria to the site to cause the skin infection. So it's always a good idea to sanitize yourself before you do anything. Alright, now I'm going to set up the needle. For this stick, I'm only going to want 1 cc, and I had to make sure the bevel is facing up and the cap is facing away from me so I will not obscure my line of sight. Alright, now that everything's all prepared, I'm going to prepare this cap right here, take off the needle, or take off the cap from the needle, hyperextend the wrist, and come in at a 45-degree angle. Alright, and now I'm going to stick the patient, and I can tell I hit an artery since it flashed and it's filling it relatively quickly. Alright, now that it's full, I'm going to take this out and put pressure while I close the protection cap away from my body. I'm going to take the needle off and put the air bubble cap on. As I put pressure on his puncture, I'm going to take the bubbles and put them to the top by tapping it, and I can press the blood into the cap and take out any excess bubbles. Now I'm going to shake the ABG to mix the heparin and the blood together. Alright, and usually you would want to hold the gauze for 5 minutes, but it's more important to know that the patient has stopped bleeding and that clotting has occurred. Once you check it and you see that is so, you can either just toss the gauze away, or if it makes the patient feel better, you can apply a band-aid to the site. Alright. So after this is done, I can put the ABG in the biohazard bag with the requisition slip attached to it. I'm gonna clean up my area, get this stuff away, and I will dispose of the needle into the sharps container. Take off my gloves, toss this away too, and I'll wash my hands, and I will make arrangements to go test this arterial blood gas. So if in my arrangements I cannot, if I know I cannot do the testing within 15 minutes, I will put it into the ice bath or the ice slush. And if I don't test this within an hour, I had to redo the whole sampling. I had to get a new sample because this sample is no longer good. There's too much metabolization that went on, and it will give me an inaccurate sample or reading. So now I'm gonna go and analyze the blood gas. I'm going to get the results back. I'll interpret the results, and I will make a modified plan for the patient as needed. Now I'm gonna chart my findings and my plans, and I'll report it to a person that needs the information, such as a physician or a nurse or another RT. So 3 non-invasive alternatives to an ABG would be a transcutaneous blood gas monitor, a capnography, and pulse oximetry. And there are reasons for variation in sample size. For example, the arterial blood gas analyzer may need more or less blood, which will require maybe more than 1 cc or maybe even less than 1 cc. And also, it's always nice to ask a nurse or physician if they need blood, an arterial sample, so that could dictate you taking more or less blood from your patient. And excess fluid heparin can obscure the sample by making it seem as though there is less CO2, which can make the pH higher, alkalotic. And the reason for that is that it dilutes the sample. And for complications that an ABG can for complications that goes along with the ABG are that you can have pain involved, a hemorrhage, arterial scissoring, and also an arterial spasm. And you should wait at least 30 minutes when you oxygenate a patient or give him a new device. You should wait at least 30 minutes before taking an ABG. You want to have a stable oxygenation rate before doing anything, or else it will be inaccurate. And that's it. Thank you for watching.